It's my pleasure to welcome Boris Lams. Boris is a consultant chest physician, works in the critical care as well, and has been instrumental in working with the ECMO program, particularly for the interstitial lung disease, and he's going to give us a presentation today about is this ARDS, so cases about ARDS. Thanks, Boris.
Thanks, Luigi. So that's right. So I work both in the ILD service and in the severe respiratory failure service. And these cases, and it is a series of cases, represent the overlap of those two disciplines. So the majority of ARDS which we see on retrieval, out of those, some have a relatively clear cause. You know, some have pancreatitis, some have meningococcal sepsis, some have been run over by a bus, and it's all relatively straightforward. But there is a whole section who don't have a clear cause. And a lot of those referrals are sort of labelled as ARDS secondary to pneumonia. And, you know, some of them are. So this is Legionella Pneumonia. It's a 50-year-old, presents with sort of 5-6 days of cough, shortness of breath, progressive infiltrates and hypoxia, lobar pneumonia, and with a sort of ARDS pattern. And Legionella antigen positive. Treat the Legionella, treat the ARDS, and gets better. So reasonably straightforward. Here's another reasonably straightforward one. So this is young girl with flu B and staph superinfection. Comes in again, 5 days of progressive shortness of breath, progressive infiltrates, fever, sweats, raised CRP, and we've got flu on the lavage, and we have staph on the lavage. We treat that, treat the ARDS, and she gets better as well. So those are reasonably straightforward. But of course, not everything labelled as pneumonia and bad ARDS is actually such. And I'm just going to run through a sort of series, starting with the more straightforward and then going towards the ones which I'm not entirely sure about. So this one is a 73-year-old man, and he presents with a 2-week history of purulent blood-stained sputum and fever. He's got a background of this 1 month of aches and pains, which I think is significant. He comes in, here's his x-ray, so he's got infiltrates down the right mid and lower zones, pretty unilateral, pretty focal. His CRP's up at sort of 300. He's got fevers, and he's got a white count. So he gets labelled as pneumonia, fair enough. And he's given some antibiotics for that, fair enough. But he gets worse. And over the next 5 days, he progresses, he develops an AKI, becomes anuric, worsening oxygenation, and his blood continues to come up. His X-ray deteriorates, so he gets bilateral infiltrates now, gets taken to ICU, gets intubated, has a bit of a pneumothorax, arrests a couple of times, and is then in trouble with his CO2 and his pH. And he's retrieved on ECMO, and it's often the case, but by the time they come in, it's largely uninterpretable because there's so much white. But there is a bit of a gradient. And so you could call this pneumonia with ARDS, but it's odd, isn't it, to deteriorate. He was in single organ failure, there's a lot of blood coming up, and he was anuric. And as you probably guess, he was ANCA positive, PR3 positive, and so we gave him a diagnosis of granulomatosis with polyangiitis, which is what we're now supposed to call it, GPA, open brackets, formerly known as Wegener's, close brackets, associated diffuse alveolar hemorrhage. And so he had standard induction therapy back then, methylprednisolone, plasma exchange, cyclophosphamide. I thought he was going to do really badly, actually, because pre-ECMO, all our ANCA-associated vasculitis, we could get them better, we could stop the bleeding, but they were so damaged by the ventilator-associated lung injury that they had a torrid time. He did really well. He goes from this to this in 10 days and goes back to his referring hospital on 2 litres. So I think the clues are obviously hemoptysis and the fact that he didn't get better. I think if you go out to see somebody who's ventilating because they've been in hospital a couple of days and they're coughing up blood, then you've got to think about an ANCA-associated vasculitis, or PVS. I mean, there are other alcohols, but ANCA-associated vasculitis is something you've got to be thinking about. The low hemoglobin, if you look at the hemoglobin drop and somebody being admitted to ICU, it always drops with the pneumonia, so I'm not sure that's a great sign, but it's definitely there. And then there's the prodrome, the arthralgias and the fatigue, and that's often missed because it's all the chaos of the admission. But the prodrome was there, sort of 2 to 3 months of feeling unwell. And also the absence of full-blown multi-organ dysfunction. So they're not on bucket loads of inotropes. They're not behaving in that super septic way. And so you think, well, why has the lungs developed an ARDS when the rest of the circulation isn't falling apart? So those are the sort of clues to there's something else going on. Here's a similar one. She's 21. She's unwell for 3 months. She just stays in her room, doesn't come down, a bit achy. So that's not right. And then 3 weeks of cough, fever, and hemoptysis, goes to a GP, gets some antibiotics, goes back, gets more antibiotics. A third time goes to a GP on the Friday, and her mum said, look, this isn't right, and she is correct. She gets admitted on Friday. I don't have the original X-ray, but it showed bilateral infiltrate. And she gets given a diagnosis of atypical pneumonia. And whenever you see atypical pneumonia, I think that is a worry, because the radiologists have put down this is infection with atypical features, and then the attending physician then says, oh, that's an atypical pneumonia, I know how to treat that, I'll give them some clarithromycin and now I can go to bed. But it's always a worry, atypical pneumonia. Anyway, intubated on Saturday, and by Sunday she looks like this. So she's got bilateral disease, unventilatable, and comes in on ECMO. So the only air at this stage is in her colon. And here's her CT, it's virtually uninterpretable. But again, it's the blood, it's the rapid progression, it's the prodrome, and indeed she was MPO positive, so she's ANCA positive. So we gave her a diagnosis of microscopic polyarteritis with associated diffuse alveolar hemorrhage, not really an ARDS. And again, clues are the hemoptysis, low hemoglobin, the prodrome, and again, she was just in pure single organ failure. She can't really get herself like that if it's a pneumonia with ARDS, unless there's something else going on. So that's the AAV. Here's her treatment. It's a rituximab-based regimen, and she rapidly got better. So she's no tidal volumes to 500 mils, and then extubated, and then she's back self-ventilating on air 14 days after admission. And here she is. She walked into clinic about a month later, and she's fine. She's 21, she's fine. The other thing is that don't be fooled by the CRP. So everything which is a CIP is not infection. So these are a series of AAV, so ankylosing vasculitis. This is the ECMO group, and here's the pre-ECMO group. And you see they all come in, or the majority come in with high CRPs. The other interesting thing is the ECMO group. Look at the CRP. The CRP fall and stays down, and they do really well. This is the pre-ECMO group. It falls, but then it bounces. And I think that's all the inflammation induced by the ventilator. But I don't know. I think it is. Anyway, so a raised CRP does not equate to infection, obviously. Here's another one. He's an interesting guy. He's 21, and when he was 14, apparently he went into hospital with with asthma. And his mother said the doctor said it was asthma, and he was really unwell, but they couldn't hear any wheeze, so they thought it must have been silent asthma. And then he was fine. Yeah, well, he probably was. Then he was fine until he was 21. No pumps, nothing. And then he goes to work in a bar, earns some money, and starts smoking cigarettes. And 7 days after he starts smoking cigarettes, he starts to feel unwell. He's got cough, fevers, and more short of breath. And then 3 days after that, he goes into his hospital with fevers, sweats, his CRP's up, pretty high, I think about 300. His white count's up at about sort of 20 or 30, with a neutrophilia. Okay? And this X-ray. He's labelled as an atypical pneumonia and a bit of asthma. And this is the 4th of July in the evening. And here he is, the 5th of July at 11 in the morning. He's intubated and he's got bilateral infiltrates. And this is an hour and a half later, 12:37 on the 5th of July, and he's unventilatable with bilateral infiltrates. And again, so he was labelled as an atypical pneumonia, which has suddenly gone bad. But he was sitting there, no inotropes, peeing, and absolutely fine. And he wasn't wet. And his heart was okay. So here's his retrieval. Again, no air. And here's the clue. So here is his eosinophils going up. And they go up to 4.5. And here's the first dose of methylprednisolone going in. It suppresses him, and then here's the post-bounce. You get this bounce when you take off the methylprednisolone. You just give him some more methylpred, and he comes under control. And the nice thing about acute eosinophilic pneumonia is they rapidly get better. So here he is 2 days later. He's off ECMO, and here he is in clinic about a month later. So acute eosinophilic pneumonia, there's a lot more of this about than people recognise. And it doesn't always come with massive eosinophils. And it usually presents with fever and a raised white count, and when it starts, it's a neutrophilia. And they have a raised CRP, and they look like a pneumonia. But there's this rapid progression, so they're always in ICU within 24 hours, and they're always ventilated, within 24, 48 hours. And then the eosinophils go up. So I think, and the nice thing about them is they are exquisitely steroid responsive. So those are sort of AAVs and acute eosinophilic pneumonias, and I think they're all pretty standard, and they're in the literature. Now I'm going to move on to some which we found maybe a new group. So this is a 42-year-old female. She presents with 6 months of arthralgias and malaise, and then she starts to get short of breath from around about the 1st of February, and she's admitted. She's treated as acute pneumonia because she's got bilateral infiltrates. And then she just gets worse. Her oxygen requirements just slowly step up bit by bit by bit. You know, she goes to CPAP, she goes, FI2 goes up, la-di-da-da, then they ventilate her, and they put her on lots of antibiotics, antifungals, anti-TB, and she looks like, this is the first X-ray I've got, which is admission to ICU, and you can see she's got bilateral infiltrates. That's a little odd for a pneumonia, and she's in single organ failure. Here's her CT. I'm not going to dwell on the CT because Suja's going to go through this, but there is a sort of perilobular pattern, and I think, you know, you've got to, if there isn't a gradient and there's a little perilobular pattern, you've got to be worrying about something funny going on. And then there's this sort of diffuse airspace shadowing up here, ground glass. And this could all be, you know, flu. It looks a bit like flu, but flu was negative, and it's long and slow and single organ. And she just gets worse. Here's 2nd of March. Here's 4th of March. And then she can't be ventilated, she's retrieved on ECMO, comes across, oops, that was a little whoops. But I mean, otherwise she's, again, got sort of bilateral infiltrates. And again, she's single organ failure. And she's got these slightly ragged cuticles, which means something to the rheumatologists. And again, she has this 6 months of joint pain and malaise. So we thought she had a rapidly progressive ILD, possibly in the setting of an underlying connective tissue disorder. And she was stuck there. You know, and after a week, we said, OK, fine. She was dead but for ECMO, so we might as well just give her everything. So we gave her everything, which is methylprednisolone, rituximab, and cyclophosphamide in a nice big dose. And then we thought we'd get rid of stuff with plasmapheresis. So we plasmapheresed her as well. And people said, what are you doing? We said, well, I don't know, but it's probably inflammatory. And we didn't have a serology back at this stage. And she went from this, she was slow, okay? She didn't turn around like the acute eosinophilic pneumonia, she didn't turn around like the AAVs, but she got better. Here she's on the 2nd of April, and here she is on the 15th of April. So it's weeks you have to wait. And then in the middle of it, she came back as JO1 positive, which is sort of an anti-synthetase antibody, and SSA positive, which is what we used to call RO, I think, yeah. So anyway, so then it's these two, which if you get those two together, that's always bad. And no features of myositis to go with what we thought she probably had, which was a thing called a clinically amyopathic dermatomyositis. So inflammatory sort of dermatomyositis, but without the initial myositis. Interestingly, now she's developed a myositis later on, so she's morphed. But she did well initially. And this is her in clinic, and she came into clinic 96 on air. So it's good. And the clues, again, it's the single organ failure and the rapid progression. It's those people who are sitting in that CPAP hood reading the newspaper, you know, because they're fine. You think, what on earth is going on with you? And you've got to think that it's inflammatory. Again, the ragged cuticles, the 6 months of the joint pain, the perilobular pattern on the HRC, and if you've got it, the serology. This guy, again, is slightly more complicated. He's 45, he's got seropositive rheumatoid, and he's maintained on methotrexate, infliximab, which is a TNF inhibitor, and a bit of pred. And he's fine, okay? He's high-powered executive, and he's skiing, okay? He doesn't look like he's got rheumatoid, his joints are all fine, because he's under control. But then in 9th of March, he comes in, fevers, cough, shortness of breath. Goes in, here's his local admission film, and he's probably got something going on down here. He gets treated with some antibiotics to cover a community-acquired pneumonia. This is the next day, and he's worse. And you can see now he's got infiltrates over here, and he's got a bit of a pleural effusion. Oh, no. What's good? But he's still in single organ failure. And they tap the effusion. It's got sort of a bit cloudy. They drain it. They give him some antibiotics. He grows a strep. He gets a bit better, but then he just goes clunk, clunk, clunk. Worse, worse, worse. O2 requirements go up. He goes to ICU, and he does the CPAP, the hood. Then he gets intubated. Standard. And look, he just progresses, and he's always in single organ failure. So it's difficult to say, oh, you've got rip-roaring strep, and you've got widespread sepsis, and you've got an ARDS related to that, if you're sitting there peeing and, on no inotropes. Anyway, he just got worse. Here he is by the 18th of March, and by then, he's on anti-tuberculous therapy, and he's on antifungal therapy, and he's on lots of antivirals. And I fully understand why people do that, but that's not what this is. And by then, he is unventilatable, and he's retrieved on ECMO, and here's his coming in film. And again, here's his CT. There is sort of a hint of perilobular pattern, and it doesn't have that gradient. And it's not one thing, it's just the whole thing altogether. So we didn't know what was going on. We thought he had some sort of acute interstitial pneumonitis, like in the olden days we used to call it Hammond-Rich, related to twitchy lungs. So that we thought he had a bit of rheumatoid, which makes you twitchy, a bit of methotrexate makes you twitchy, TNF inhibitors definitely make you twitchy. Then he's had the infection, and that sort of made him extra twitchy and flipped him over the edge. And then you've got a bit of ventilator-associated lung injury going on and a bit of high FiO2. So you've got lots of pro-inflammatory things going on. And again, he was stuck, for a week, and then we said, all right, we'd better do something. So we gave him this regimen, but we missed out the cyclophosphamide because we were slightly anxious about the infected pleural space. And he made a remarkable recovery. Here's his CRP. Look, he's banging along at 400, his CRP. Here's the methylpred going in. Look at it, it just drops. And he gets better. He goes from tidal volumes of 0 up to 400 mils in 1 day. And I show this and say, oh, you've just dried him out. He was crispy dry, the day before this, and his balance was plus 500. It's inflammation. And here he is when he came to clinic, so only about a month later, and look at his CT. He's got virtually no damage at all, no fibrosis. He's got a little bit at the top. That's all sort of pre-ECMO ventilation. So what were the clues? No, I'm not saying it's a bad thing. I'm just saying that's why it's there. Anyway, so look, so we thought he had, the clues with him is he's got an inflammatory background. He's got the rheumatoid, the methotrexate, the TNF inhibitor in the background, and then he's got this rapidly progressive severe respiratory failure, and it's all single organ. It just feels inflammatory. And here's our series of the people who we think don't have pneumonia and probably need some immunosuppression. It's grown bigger now, but we've got about 4 more in this group and 4 more in this group. This is the responders, and these are the non-responders. And we give them all this methylprednisolone and cyclophosphamide rituximab. Some of them do well, and some of them don't respond. One of them had a lung transplant, but there are 2 groups. And the only thing the only difference is that the responders have a very high CRP. See, it's 497,350, an average of 328, compared to the non-responders who have a CRP over 91. And also, the responders come in quickly. So they're 20 days from first symptom to ECMO, whereas the non-responders are longer. So it looks like the hotter, more inflammatory, more acute ones do better. And there's a whole bunch of diagnoses here, which we try to attach to them. So that's, the inflammatory lungs. And the Lazarus paper where they took all comers with ARDS, and it was sort of a negative thing when they gave them all steroids. I'm sure, but there were a bunch who did better, weren't there? And I'm sure within that ARDS population, which were labelled as pneumonia and ARDS, that they're these inflammatory ones, and they're the ones we're going to try to pick out. But I thought I'd finish with this one. This is a sanitary lesson, just so it can be a little bit tricky. She's 33. She's got U1RMP positive disease, which gives her this thing called mixed connective tissue disease, which is a bit like having scleroderma and a little bit of myositis. Previously inducted with methylprednisolone, maintenance AZA and pred. Here's her CT when she first presented, but probably okay. This is probably a bit of a dependent change. She got pregnant. She was on a bit of AZA and a bit of pred. She got cholestasis of pregnancy, put on some rifampicin, and then she came in at 30 weeks, weak. Her CK was up. She had a mild shortness of breath, cough, low platelets, and elevated liver enzymes. And it wasn't clear exactly what was going on. She did perhaps have a little bit of new change at the base. Her CK was up. It felt a bit like her first presentation when she presented with her scleromyositis. So was it a flare of MCTD? Rifampicin was eating up the pred. Was it some sort of help, although she wasn't hemolyzing, she had the other features? Something else. So they gave her 500 milligrams of methylpred, bit for the baby, bit for the mother. Unfortunately, she sort of promptly went into septic shock, had a really hairy sort of a caesarean section, lots of blood products, lots of hemoptysis up the tube, and went to ICU. And here's a picture on ICU there. And you think, well, bit of Trolly, bit of ARDS, you know, she's been through quite a lot. But she just didn't get better, she got worse. And she was seen locally, and they thought, oh, well, she's got ongoing pulmonary hemorrhage, which she did. And they thought, well, she's probably got a pulmonary vasculitis, you know, related to the, she's got an inflammatory field, pulmonary vasculitis. They gave her sort of 3 grams of methylpred and 2 cycles of Plex, which is pretty good treatment for pulmonary vasculitis, but she got worse and worse. Platelets were 3, and she started to bleed from everywhere. So she was retrieved on ECMO, and again, looked bad. And here's a CT. The only thing which you could possibly say is there is a little bit of sparing around the edge, which you sometimes do get with alveolar hemorrhage. So was this alveolar hemorrhage? Well, I think it probably was. But it's a little odd to get pulmonary vasculitis in MCTD. You get it in the anchor-associated vasculitis, but it's odd to get it in if you don't have an anchor. And indeed, her CMV viral load was the highest we've ever recorded at 24 million. And I think this was all CMV-related disease. She had inclusion bodies. She had, and I think the platelets were a combination of immunosuppression and CMV attacking the bone marrow and her guts. Her guts fell apart. She had a torrid time, but managed to pull through on IVIG and antivirus. She went from that to that, and then went back. Unfortunately, she then died of a non-pulmonary event. So that's a long story cut short, but it's just to show that sometimes it can be a bit difficult, and it's, you know, I present them as though they're clear-cut and they're not. So, in summary, not all pneumonia and ARDS is such, and the key is to tease out those that will respond to immunosuppression, and then immunosuppress them, I think, early and adequately without missing underlying infection. And also, you just need to be in a constant state of low-grade anxiety because, you know, whenever you think it's going right, it's probably not. And that's the team. Thanks.